So welcome to the Confidence Interval, an occasional podcast from the MRC Epidemiology Unit at the University of Cambridge. We're talking science, people and public health. So the idea is to use this podcast to explore the research happening at the unit, meet some of the researchers and find out what makes them tick. I'm Oliver Francis, Head of Communications, and today I'm very happy to be talking with Dr. David Ogilvie, Programme Leader and MRC Investigator in the Population Health Interventions Group. Good morning, David.
Good morning.
So David, you specialise in the relationship between transport, the environment, physical activity and health. And you've established and led an interdisciplinary group of researchers working in this area, particularly on the design and analysis of natural experimental studies, such as the Commuting and Health in Cambridge study, iConnect, and the M74 studies. So we're going to talk a bit about active travel, but it's a broader canvas that we want to kind of explore today about your wider interest in the design of population level intervention studies and evidence synthesis more broadly. Questions like how do we evaluate interventions and phenomena that are tricky to evaluate? How do we put together these findings from multiple studies in a meaningful way? And what do we do with all this evidence once we've put it together? So, I will ask you a question in a minute, I promise. It's been a while since our last podcast, over a year, and it's been an unusual year to say the least. We're not going to be talking about COVID too much in this episode, but I did want to reflect that, in the UK, we've had one of the worst death rates and economic impacts of countries around the world. But at the same time, we've done really well in vaccine development and vaccine rollout. And it seems like a kind of microcosm of health in this country. We're good at medical science, logistics, healthcare delivery. What we seem less good at is dealing with complex underlying public health problems. And it almost feels like there are kind of long-standing public health problems that have come home to roost, whether it's obesity, housing, employment, inequalities. And in science too, while we've been very successful with rapid vaccine development driven by randomized control trials, many other aspects of the pandemic have shown the limitations of these medical models in guiding the questions of what we should do. So David, you actually started out in medicine and qualified as a doctor, but like lots of doctors I know, you followed the lure of both public health and public health research. So you've experienced both sides of this public health medicine question. And rather than being of the opinion that we should actually, in public health, take more lessons from the medical model, you've said that actually to solve some of these complex problems that affect whole populations, we need to turn the evidence-based medicine paradigm on its head. What do you mean by that?
Well, it's important, I think, to start by saying that my practice of public health and public health research is very strongly shaped by the fact that I was a doctor first. And so, when I was working in general practice, for example, part of the reason I wanted to move into public health was I was seeing patients whose problems were not soluble by a prescription or a medical procedure. The roots and the responses to their problems lay further afield in society, further upstream. What I mean by turning the paradigm of evidence-based medicine on its head is that evidence-based medicine has served us brilliantly well for some things. For example, working out whether new drugs or new vaccines are safe and efficacious. But the whole premise of a linear model where we start in the lab, we move into testing in human volunteers, and we end up rolling out treatments or other interventions to the population doesn't fit very well with a view of public health in which the social, the wider, the upstream determinants of health are important. And the key point, I think, is that actions in those arenas that affect people's health are going on all the time, whether we evaluate them or not, whether they're based on evidence or not. And researchers can't really make them happen or make them stop. And so people like me who want to research population level strategies or solutions, we can only evaluate things that someone else has decided to do. And if we narrow our perspective to the evidence-based medicine pipeline idea, then a lot of things will never be evaluated because we'll never reach a point where we think the evidence is good enough to support trying them.
Great. I mean, there's all sorts of angles to unpick on that. Just to sort of go to a practical question, I guess. There's no end of complex public health interventions, and you became interested in the built environment and active travel. And you might say, and some people talk about it like this, that it's actually rather simple. You just need to build lots of cycle lanes. We don't have enough cycle lanes. Build them, be like Holland, we'll be fine. Why is it not like that in active travel and transport?
Well, I think actually the experience of the last year of the pandemic and the way societies have responded to that illustrates that it's not that simple. Various governments, including in the UK, have installed temporary cycle lanes, and these have generated in some places a lot of objection, even legal challenges. So even in a situation where people are being discouraged from using public transport, for example, there's still resistance to doing what you are suggesting is an obvious answer. More broadly, I think, yes, a lot of people working in our field, they look to countries like the Netherlands or Denmark or certain cities within the UK, including Cambridge, as exemplars and say, if only we could have what they have, things would be different. But, as scientists, we've got to look at that as a testable hypothesis rather than a sort of easy assumption. Among other things, building things costs money, and that's money that could be spent on something else. Building cycle lanes takes space away from other things, including obviously space for cars. There's other ways of encouraging people to ride bikes. We can have mass media campaigns. We could have higher duty on fuel. How do we know which is the best way or the most effective or efficient combination of measures? The other thing that's become obvious since I started working on this topic is that different constituencies, if we can put it that way, are impressed by different kinds of evidence. And one of my early projects in this field was to work on a NICE guidance development committee. And of course, the way that NICE, which is the body in England that looks at evidence for health care and public health interventions, the way it appraises the evidence naturally builds on a health research paradigm of what counts as rigorous, trustworthy research. And when I started in this topic area, a lot of the available research about things like building bike lanes or redesigning other aspects of the transport system, they had been conducted in other disciplines with other ideas about what counts as rigorous. And but in order to make your evidence or your argument count in a health arena, you've got to find a way of measuring up against evidence in favour of other ways of improving health. And so what I've tried to do all the time I've been working on this is try to find ways of bringing a health research perspective to a topic that really spans many disciplines in order to make the evidence more convincing to more people. Another thing we've discovered more recently is that while some people are motivated by examples in other countries, other people, they want something concrete they can look at as an example that's just down the road in a place like where they live. And in one of the recent PhDs from our group, this has been developed as the idea of a believable story. For some people, the idea of importing directly some solution from the Netherlands is a step too far without first showing actually it also worked in London or it also worked in some other place closer to home.
There's a Dutch style roundabout about half a mile from where I live, actually, and that's been interesting. And you've got this one roundabout that's completely different from all the other roundabouts. And of course, early on and still now, people don't quite know how to use it because it's just sort of one intervention. And I wanted to pick up on a couple of thoughts in there. It's this idea that constantly more research is needed, that is a kind of battle cry of scientists, that you constantly have to find different sorts of evidence and put it together. And some people would say that actually you just need to do more randomized control trials because they're the best type of evidence we have. You can put a Dutch roundabout in Cambridge and you can test that and you can compare it to one in Peterborough or whatever. What do you say to this idea that surely we should just randomize more rather than trying to observe these messy real world things that happen on their own? Shouldn't we intervene more and use that RCT model for seeing if things work?
Well, I think we could do more randomized controlled trials of public health interventions in general. And where that's a sensible and feasible thing to do, then yes, let's have more of them. And we've explored ways of trying to start them in various ways, but there are often quite difficult obstacles in the way. The other side of it, though, is just doing more studies isn't the answer, because along with piling up a stack of evidence, we also need to work on the way we put it together to make conclusions that are meaningful in places that are not the same as where the research took place. Because you can't get away from the fact that if we decide to build an unusual roundabout in Cambridge or a motorway in Glasgow or something like that, there's always going to be something about the local context that is specific. And if we don't understand that, it's very difficult to say to someone living in Birmingham or Bogota, well, the same thing would apply there. Where we've talked about turning the evidence-based medicine paradigm on its head, we are not arguing that randomized controlled trials have had their day or are not useful. Quite the contrary. It's just that insisting that everything has to be evaluated in that way means, in a way, we're exchanging one kind of bias for another. The whole premise of a randomized controlled trial is to minimize the risk of bias in comparing the intervention group with the control group. But if we insist that only randomized controlled trials provide convincing evidence of effectiveness, we are effectively saying if you can't randomize it, you can't evaluate it, so you can't know if it's effective or not, so it will never be implemented. And, some things are easily randomizable, but others are not. And the ones that aren't are not necessarily things that we should just discard as pointless or unevaluable.
And I think sometimes arguments about whether we should randomize are purely technical ones. They're about, is it possible? How would we do it? That kind of thing. And almost you're saying we need to go up a level, and it becomes not quite philosophical, but we have to kind of think about ways of thinking, ways of knowing, how we understand the world, how we put the world together. And it's not necessarily a purely instrumentalist way with, neatly lined up facts, which sounds very unscientific. But I think perhaps it's a way to look at it is I usually wait to the end of the podcast to ask my guests about fiction, but I happen to know you're a bit of a Sherlock Holmes aficionado. So I want to talk about Sherlock Holmes because it's always a good excuse to talk about Sherlock Holmes. Now, he's famous for deduction, but actually a lot of time he's not doing deduction. Deductive thought, this idea that you draw specific conclusions from general principles, but rather inductive reasoning, which Holmes would observe lots of things in the world and connect them together to arrive at something unseen immediately from the evidence themselves. He would essentially build new theories. And of course, the latter type of thought, inductive thought, requires a great deal more tolerance for uncertainty and actually in Holmes's work, guesswork, and because he's brilliant, he guesses it right. And, we kind of forgive the logical leaps that Conan Doyle allows him to make. But to come back to sort of you and your science, this idea of uncertainty is interesting because you've written both about reducing critical uncertainties, but also, as I say, being tolerant of uncertainty, not letting uncertainty become a barrier for a certain level of action. But how do you tell the difference? How do you know when you've got a critical uncertainty and a tolerable uncertainty?
Well, I think part of the answer is that in the type of public health I'm talking about, we don't have the equivalent of Sherlock Holmes needing to definitively prove that a particular person did the crime. One of the implications of the randomized controlled trial way of thinking is that it becomes, or easily becomes, a binary judgment. This treatment works or it doesn't work. We may come back to that later, but
there are lots of dogs that don't bark as well, aren't there?
Yes, there are lots of issues that one ought to think about carefully as to whether that is a meaningful way of thinking about ways of intervening in complex public health issues where there are many factors interacting with each other. And I think in our research, I think we're doing both deductive and inductive reasoning. Yes, we may start a study motivated by an underlying hypothesis. For example, if we build new bike facilities, people will cycle more. That is a testable hypothesis. But as you say, the inductive approach is also essential because we're always investigating complex, messy situations in which, as humans, we have a remarkable capacity to subvert the intention of the intervention, to find ways of interacting with it that weren't anticipated. And those will vary in time and place and person. And so in our studies, while we have an organizing hypothesis or set of questions that we start with, we always end up discovering things that we didn't even know we were looking for. And I think that's important because our fundamental understanding about the phenomena we're investigating is still quite patchy.
It feels, I mean, without stretching the metaphor too far, it feels like detective work when you talk about, you find unusual clues you weren't looking for necessarily. And I've heard you talk about the importance of shoe leather epidemiology and the world as a living laboratory. And do you think the fact that you can't control the parameters of your experiment, as it were, perfectly, makes for a more kind of satisfying, interesting process for you? Do you like the fact that you're kind of snuffling around in these unusual places and you don't know what you're going to find? Does that kind of add to the frisson of discovery?
Yeah, it's interesting you put it that way because there is a phrase, discovery science, which most people take to mean, discovering a new molecule, for example. And the kind of research we do is not like that. We're not going to unearth something that's not been recognized in biology before. But at the same time, yes, I think for me, science is a process of discovery. It's a process of trying progressively to reduce our uncertainty about things that are important. And you could see the whole history of science like that.
I mean, I don't want to sort of be down on lab science in the sense that to say that uncertainty and serendipity isn't important, because I think it is across science. And I think one of the ways that science suffers in the popular imagination is this idea that it's a list of facts, that it is the discovered things rather than the process you go through towards discovery. And I think perhaps in your work, it's just writ very large that it's a messy journey in a way that perhaps it isn't so evident in some other disciplines.
In one of our recent papers, there's a whole section headed Embracing the Mess as part of the strategy of science that we describe. The mess often occurs where the intervention we thought we were going to evaluate turns out to be different. It's been delayed, it's been changed. People have used it in ways that weren't anticipated. And also the pattern of findings that we uncover is never straightforward. One of the authors whose work I've drawn in some of my recent papers, Penny Haw, has described the feeling that we want a neat, coherent story in our research projects. And I have to say it's very difficult to produce those in our work because there are always findings that are a bit contradictory. Different groups of people respond in different ways. We can have an effect on one outcome but not another. And, we're dealing with complex situations in which individuals interact with an intervention but also with each other and with other things going on in the public realm. I think it's going to be complicated. It's going to be messy. And I would rather we admitted that and see what we can understand from the variation and the patterns we see in the data, rather than try to force things into too narrow a view that says, did it work or not? It often begins to feel a bit of a meaningless question. Does the intervention work? It depends what you mean by work. It depends what you mean by is, and it depends what you mean by does.
Sounds like a politician's answer.
Well, but it's actually more of a philosopher's answer because, again, if we go back to the trial paradigm, many trials, especially in the past, were set up on the idea that there was a single main outcome against which your treatment would be evaluated. But the kind of things we investigate, not only in the transport arena, but also in the food system or the welfare system or other areas of public policy, a particular policy intervention is likely to affect many different things. Now, we as a researcher in a given topic might think that, let's say, an impact on overall physical activity or overall dietary quality or something like that is the most important, but not everyone will agree with that. What we tend to find is that interventions affect some outcomes more than others, but it's quite hard to make a moral judgment about which of those is more important. If we're asking, does the intervention work? Well, what is it? Most of the things we study are quite complicated, and you can have a policy that triggers off a series of secondary responses from various other actors in the system, and that might vary according to where you live in the country. And then does it work? Well, what do you mean? Do you mean did it work when it was studied in that trial? Or do you mean will it work if we implement it here? Those are two very different questions. And, there isn't a straightforward answer. So rather than a political kind of woolly answer, in saying that, I'm trying to get to a more honest kind of science that recognizes that it is complicated and we shouldn't pretend otherwise.
And you mentioned stories and this idea of being honest about interpreting your findings of what they mean. Is there a danger that we're confronted with these unfathomable systems and we tell ourselves neat stories that make sense to us, but actually bring in all our prejudices, which are very hard to filter out? We can be as rational as we want with the data, but actually we are creatures that are shaped by our own worlds. How do we make sure that we're not just telling ourselves stories that we like?
Well, we do need to be honest about what motivates us to research certain areas and to choose certain questions and methods to focus on. And, in some areas of research, this is more overt than others. In a lot of qualitative research traditions, for example, you're expected in a paper to describe in a reflexive kind of statement what you as an individual bring to the endeavour. In areas like epidemiology, that is less of a tradition to be explicit about that in a paper. But that doesn't mean that the decisions being made are value-free or disconnected from your personal perspective. So I think it's important to be open about that. And in many of our studies, for example, although we might study things going on in the built environment, which obviously relate to many policy areas, possibly housing, climate, air quality, as well as how people move in terms of physical activity, every study is going to have its own particular motivations. And that might mean, for example, that we don't have the capacity or the expertise to look at all the outcomes of interest. So, for example, where we studied a motorway project in Glasgow, we were explicit in saying we are not in a position to evaluate the overall economic impact of this investment on the regional economy. And, unemployment and freight journey times and things like that. These are important, but not our bag. But what we are doing is using a particular opportunity to advance our understanding about a part of the map that is our bag and combining that with others. So maybe it's about being explicit what we are trying to do, what we are not trying to do, and therefore what we're not going to comment on, except to admit that others can fill in other pieces of the jigsaw.
Which is a good moment, I think, to talk about this wider picture, this wider map. And another metaphor that you've used recently, this idea of a dry stone wall. Because, you have all these studies, and at first glance, you would see that science has solved this problem of combining multiple studies. We have this thing called a systematic review, and every PhD student, that's where they start in their research. They review all the evidence in the area, and they go, okay, what's missing, what next? Do you think this process is coming up short, and how might we make it better?
Well, I think the development of the idea of the systematic review and some of the specific methods used in it, like the meta-analysis, has been, transformative in how we put together multiple sources of evidence on similar questions in order to guide decisions like whether to use a particular medical treatment. I mean, it is a very admirable and important thing that we as a field have done in the last decades. The issue for me is that, as with the trial paradigm, some of the questions that we look at don't easily get forced into some of the traditional ways of doing it. And I mean, this became apparent to me as soon as I started work in public health as a registrar in the NHS before I did any research. Because I would be looking at projects in the health service like how should we redesign outpatient services for a given condition? And I'd go to the Cochrane library and look for the systematic review, and the systematic review would say, well, we've done a review, we didn't find any randomized controlled trials, so there's nothing we can say. Now, I mean, it's a valid conclusion in one sense, but it's not very useful. As we've gone on to develop more studies of our own in the field, rather than trying to put together the findings of existing studies, what we find is that while we have a common motivation for all of our studies that look at promoting walking and cycling and so forth, the actual studies by necessity are all quite different. And so it's very difficult to force them into a model of synthesis that requires a degree of homogeneity, of similarity. And so the metaphor I'm using for this now is often in a systematic review, especially a meta-analysis, which is a particular statistical way of combining different study findings. That is like building a normal brick wall like you might have in your house. Okay, so the bricks are all quite similar shape and size. You make a nice regular structure and that serves a certain function. But most of the public health topics that I have worked on, if we can think of the terrain of the evidence we're building on, it isn't a flat building site. It's more like a mountainous area where there's rocks and bogs, and it's more like sort of herding sheep in the mountains. And that kind of wall you don't see those walls in those parts of the world. You see, certainly in Britain, upland Britain, you see a thing called a dry stone wall, where stones that are very different shapes and sizes are fitted together. If you see all the stones piled up on the ground, you can't see how you would make something of them. But if you have the right skill, you can put them together to make a robust structure. You don't need any mortar. Each stone, it brings something unique to the puzzle. It works because they're different. And so it seems to me quite a good metaphor for what you're trying to do, is to find a scientifically rigorous way of combining bits of evidence that do not marry up in a neat, tessellating kind of way. And the challenge is how to convert the metaphor or the aspiration into a method. And we've been working on trying to explore ways of doing this, but that's definitely a work in progress.
Because it's a lovely metaphor, because it has such a physicality to it, and I think we can all imagine doing it as well. I think that's really helpful. I was piling up logs of wood the other day, and I had that similar feeling of you can make them all stack if you choose the right ones. And in a funny kind of way, it's almost more like people behave in normal life. This heuristic way we have of solving problems. We as a species, we tend to kind of use what's around us, work our way forward slowly. Sometimes the wall falls over, we start again. It doesn't feel at odds with a way of thinking that a lot of people will be familiar with, and actually people in policy might recognize actually very well, because they're not always dealing with perfectly shaped bricks. They're always having to kind of put imperfect bits together to solve a problem. Now, when I first started at CEDA, which is part of the unit, nearly 10 years ago now, I'd read your 2009 paper, which looked at forming a new translational framework for public health. And this looks at how science can influence policy and health across a range of domains: media, politics, professional practice, evidence synthesis, primary research, all that sort of thing. And I remember very clearly meeting you for the first time. I said, "Oh, I've read your paper, David. It's very simple. We just need to change the world." And you gave me a slightly slightly wry smile. But I think about that a lot, and I think particularly in my area, which is trying to help scientists translate their evidence into something that's usable by policy and practice, I kind of feel that the tension between the science and the change the world aspect of it, that I think your work is trying to bridge, or you can't bridge a tension, the gap that your work is trying to bridge. The problem with this is that to do this, to change the world, we, as you've said, we need to have enough evidence to know roughly what we're changing, but we'd never have enough evidence to know exactly what we're changing and what it will do. And you've also said we sometimes need to be new, ambitious, radical. We need to do things that haven't been tried before we can know if they work or not. There's a big problem here about the issue of unintended consequences or harms. So how do we avoid that if we're going to kind of change the world, measure it, that we don't do the wrong thing too early?
There's about 5 questions, I think, in what you've just
said. Sorry,
yeah. No, that's fine. I think your comment about all we need to do is change the world is... The thing is, the we that need to change the world is not you personally or me personally. It's us as a species. Or even to be slightly less ambitious, it's we as a specialty or as a field. And I think rather than being overwhelmed by the fact that it's all too difficult, everything matters, it's too complicated, what we have to do is figure out our part in the system and what we can do. You know, there are things that can be done to perturb systems that result in a series of possibly unanticipated changes throughout the system. It's interesting, I noticed a paper recently by Ray Pawson, who's well known in social science for his work on realistic evaluation. He's been commenting on some of the research associated with COVID, and he points out that one, not the only, but one legitimate point of view is to say total comprehension of the system, all the possible things we can do to control the pandemic, is impossible. However, as he says, there's a significant rider that partial knowledge of parts of the system is A, possible, and B, very useful. And I guess that's a viewpoint I can line up with. We have to look at these problems acknowledging that they're part of a very large complex system, rather than pretending that they're simple. But at the same time, we can find bits of it that we can work on and make a difference. And sometimes that difference may be hugely significant.
I guess it's the difference. Who's the difference for? You're trying to unpack systems, so you can't change the whole system at once. You might change an aspect of the system. And is it a meaningful change for that aspect of the system? And there's a lot of talk about systems thinking now. And I wonder if it just becomes a kind of catchphrase where it's kind of like we're kind of waving our hands and saying, oh, it's terribly complex. And you've also talked about not forgetting practices of kind of anthropology and ethnography. And maybe we need to not forget that the system is made of people. And if we want to understand the system, maybe we need to refocus on some of the people within that system and understand their motivations and desires and actions.
Yes, I think, your introduction speaks about science, people, and public health. I think, public health by definition is about people, albeit considered as groups and populations as much as individuals. But I think it goes back to what you said earlier about Sherlock Holmes and shoe leather approaches to detective work. I think, especially with the proliferation of enormous data sets of quantitative information, it's not difficult to become a bit disconnected from the sort of groundedness of where those data come from, the provenance, and what the numbers mean to real people. And that's partly why I've always felt it's important to complement the bigger quantitative epidemiological picture with an understanding of what it's actually like to live in that place or ride a bike down that street. And, maybe that goes back to my days in general practice when I always understood that there was a lot more to be learned by a home visit to a patient than when you saw them in the surgery. It took more time, but you learned things that you couldn't observe in the slightly decontextualized context of a consulting room. So I do think there's partly a need to combine an understanding of the structures we live in with how we as individuals and families and groups navigate it. And that's paralleled perhaps by bringing together large-scale quantitative types of information with a more low-tech anthropological ethnographic perspective on what it's actually like. Because one of the problems with looking for statistical associations in colossal data sets is it won't necessarily on its own tell us why things as they are. It won't necessarily tell us how or why change comes about. So we can sometimes distinguish between the wish to understand causal effects in terms of estimating the size of an effect and causal explanation. How did it come about? How can we make it happen somewhere else?
Okay, so we've explored an awful lot here, and it's been fantastic to kind of hear the kind of range and depth of the ideas that you've been exploring in your work. As I said at the beginning, it's been an unusual year. Everyone kind of feels like an expert now in epidemiology. It's been a really hard and tragic year for many people. But at the same time, I think the engagement with science and with difficult, complex decision making has been really striking across the board. What have you kind of noticed in the last year that you felt has really been relevant to some of the issues we've been talking about today?
Well, I think, as you said earlier, although COVID is a communicable disease problem at face value, it has exposed some very long-running issues in public health to do with inequalities in health and to do with the importance of non-communicable disease as increasing people's risk of other conditions. And so when the pandemic is over, we'll still need to have a public health strategy for everything else, diabetes, climate change, etc. I think also the difficulty of knowing what to do in terms of rapid policy response, it does highlight a number of the scientific issues that we've been grappling with in the less urgent context of, transforming the built environment, for example. It's very difficult to reach clear conclusions about how different interventions work or don't work or interact with each other in a complex system. Is it closing schools? Is it closing pubs? Is it closing trains? How do these relate to each other? And, it's been obvious in some of the discourse, particularly in the UK, that what the science is or what it tells us is very dynamic. It changes every week. And that, some people have described that in recent months in the UK as scientists moving the goalposts, but it's not. Science is moving quickly. And the whole point of science is to build on what we already know and then progressively try to reduce the uncertainty about the things we're not sure about in order to have a better idea of what we should do. So, an example that I noticed over the last few months is the decision about implementing vaccines. Because obviously vaccine development and implementation is very much evidence-based medicine in its approach. You invent the vaccine in the lab, you try it in human volunteers, then you do clinical trials, and when the clinical trials are convincing enough, effectively we say, okay, the red light has turned to green. Now it's okay to go ahead. Until that moment, no one in the world gets it unless they're in a trial. After that point, okay, it's available. But then immediately in the UK, there was this question about, well, is a 3-week vaccine interval the right thing to do? That's what was studied in the trials. And at that point, I would argue, as an outsider watching on the TV, nothing directly to do with the process, but I observe a scientific process going on where other evidence was brought to the table along the lines of the dry stone wall we've been talking about. The trial evidence is very important, but there's also decades of prior understanding of immunology and how people respond to vaccines and other types of evidence that were brought into making a decision that actually maybe the greatest good for public health purposes would be to extend the vaccine interval, even though that's not what was studied in the trials, based on our best available understanding at the time. And crucially, then, with careful monitoring and ongoing evaluation of what the impact is, we retain the constant capacity to spot problems, to change the policy if necessary, or to accumulate more evidence that validates the decision. And that's why, rather than the traffic light model of an intervention is either ineffective and not allowed or effective and allowed, that's appropriate for medicinal products, but it's not really suitable for a lot of public health questions where it's more like we're on a journey, we're on a ship crossing the Atlantic, and the question is, what compass bearing do we set? And we may not be able to see the other side, but we can make a judgment as to, if I can put it this way, is it better that we turn to the left, turn to the right, or keep going in the current direction? And later in the journey, we'll have more information, and then we'll make another correction. And so we're always moving. We can't stop, we can't go back to port, but we can use continually evolving evidence thoughtfully put together and updated to make a more and more refined judgment about the direction over time.
Okay, so we've talked a bit about the future and, after what happens after COVID. I think that when you started out in public health research, you've been responsible for forming a lot of these ideas of how we look at these issues differently. Some researchers sort of starting out now, some of this stuff is much more natural to them, I think, particularly in public health, because of the amount of thinking that has sort of preceded their entry into the field. So given that they are entering a world that's perhaps different from the world you entered into, what advice would you give researchers in your own field starting out now?
Well, I do think that both the appreciation for what a larger range of disciplines can bring to the table, I think that's increased. And also there is a gradual shift in the emphasis of funding in public health research to spend more of it on researching solutions as opposed to describing the problems. So there is more scope for doing this kind of work now. I mean, when I chose to move from general practice to public health medicine and later to public health research, I did feel these were quite brave steps to make in a career because they felt like steps into the unknown. But whatever it was that was drawing me across those chasms was, turned out to be the right thing to do, I think. It did take me quite a long time in my career to find my niche, and that's okay. Lots of people, I think, working in public health come to it after they've got some experience doing other things first. I think, in our group, one of the most enjoyable things for me over the years has been to recruit people from a very wide range of disciplines, and we learn from each other. Anthropology, engineering, environmental science, criminology, as well as more obvious disciplines like medicine or exercise science. And so I would say to people who are working in any kind of potentially related discipline, if you're interested in working in the space between disciplines, you bring the rigor of your home discipline but also an interest in working together to, remix ideas into something useful in this more applied space, then go for it. Find a research group where that's the spirit in which the work is done, and where you can be part of something that's more than the sum of the parts. And like we said earlier, all we have to do is change the world. No, what we need to do is find our place in the system. And I think, different areas of science have different attractions, different public profiles, different assumptions about how valuable they are or how rigorous they are. But what I've concluded over time is you need to find your own place and be happy that other people are doing their thing, which is also important, but isn't necessarily what you need to do. There's a lot to do in public health research, and there's plenty of scope for people who are interested to find ways of doing it in original ways. It's not as if we've solved any of the problems yet.
Indeed. Great, that's been fantastic. So we'll post with this podcast links to some of the papers that we've alluded to today. So if you want to read the originals, please do. And I have one more question, the most controversial and difficult question of all. I've left it for last. Do you have a favourite screen Sherlock Holmes?
Well, that is an interesting question, because I'm probably not the only person who likes the books or the short stories so much that I tended to find a lot of the screen representations wrong because they don't match the pictures in my head. I do like some of the radio versions, but another conversation you and I had many years ago was about the BBC Sherlock. And I remember saying to you, I'm not sure I'm going to like it because, the pictures will be wrong. But you said, well, the thing is, they're not replicating the original stories. They're channeling the spirit of the idea and making it into a contemporary kind of reimagining. And that's exactly it. And so, yes, I like the Cumberbatch version because it complements rather than overwriting the classic original.
Dr. David Ogilvie, thank you very much. Well, we hope you enjoyed that. Thank you for taking the time to join us. You should be able to find the references to the various papers we discussed by following the links from wherever it is you're listening to this episode. And you can find out more about the MRC Epidemiology Unit via Twitter. That's at MRC_EPID, or our website mrc-epid.cam.ac.uk.